All right, so today we are going to take a deep dive into gynecomastia. And, I'm thinking we can approach this like almost like a challenging exam.
Oh, okay.
I'm going to sort of grill you and see what.
Okay, sounds good.
First off, what's the fundamental difference between gynecomastia and pseudogynecomastia?
Well, the key difference really comes down to the cause of the breast enlargement.
Right.
So in gynecomastia, we're talking about actual growth of the glandular breast tissue. And, that will feel firm to the touch.
Uh-huh.
Whereas pseudogynecomastia, it's all about the excess fatty tissue. So the key question there is, are we dealing with more fibrous tissue or is it just fat?
Got it. So anatomically speaking, what landmarks are we really zeroing in on here?
So we always start with the nipple areola complex, the NESEI.
Okay.
And we're looking at the diameter there, normals between 2 and 4 centimeters. And then we also pay attention to where it sits in relation to the midclavicular line and the fourth intercostal space.
Okay.
And then, of course, we've got the inframammary fold, the IMF, that helps define the lower border of the breast and really plays a role in how aesthetically pleasing the chest contour is.
Yeah, and it's interesting, gynecomastia, it's surprisingly common.
Yeah.
65% incidence in adolescent males.
That's right.
Now let's talk about something I think that might be on everybody's mind when they hear about this, which is breast cancer risk.
Sure.
Does gynecomastia increase a man's risk of breast cancer?
Well, gynecomastia itself doesn't increase the risk of breast cancer,
Okay.
but the exception there is Klinefelter syndrome. With this genetic condition, the risk of breast cancer is significantly elevated.
Significantly, how much are we talking?
Well, it jumps from a 1 in 1,000 risk in the general male population to a 1 in 400 risk for men with Klinefelters.
Wow.
So quite a significant jump.
That is a huge jump. So, what's the approach then if you suspect Klinefelters?
Well, biopsy is critical,
Yeah.
not only to help confirm the diagnosis, but also to rule out any signs of malignancy.
Okay, so let's move on to what causes gynecomastia in the first place.
All right, well, it all boils down to hormones, specifically the balance between estrogen and androgen. Think of it like a seesaw. If estrogen levels increase or androgen levels decrease, it tips the balance, and that can lead to the development of breast tissue.
So it can go either way. It can be too much estrogen or too little androgen.
Right, exactly.
Okay, so remind me of the three main classifications of gynecomastia.
Okay, so first you have idiopathic gynecomastia, meaning we can't pinpoint a specific cause.
Right.
Then there's physiologic gynecomastia, which is linked to certain stages of life, like puberty or even in elderly men.
Uh-huh.
And finally, we have pathologic gynecomastia, which stems from underlying medical conditions, could be hormonal imbalances, liver disease, a whole range of things.
It's interesting, even common medications, like those for ulcers or heart conditions, can contribute to gynecomastia.
Yeah, that's right.
It's wild.
Medications used to treat a wide variety of conditions can disrupt the hormonal balance, and that can lead to breast enlargement.
Now, what about histological classification? How does that play into all of this?
So histological classification, that looks at the microscopic structure of the breast tissue.
Okay.
And it helps us categorize gynecomastia into 3 stages: florid, intermediate, and fibrous. These stages reflect the changes in the tissue over time. So early on, we're talking less than 4 months, you see a more florid pattern with, increased budding ducts.
Okay.
As time goes on, beyond a year, the tissue starts to become more fibrous.
So the longer it's been present, the more fibrous it becomes.
Exactly.
Okay. Let's say a patient walks into the clinic with suspected gynecomastia. What are the key components of that initial preoperative workup?
Well, it always starts with a detailed medical history.
Sure.
We need to understand the timeline age of onset, duration, any symptoms they're experiencing, like tenderness, medications they're taking, lifestyle habits, family history.
Right.
And then comes the physical exam, where we examine the breasts for symmetry, check the NAC for anything unusual, palpate to determine whether it feels glandular or fatty, and look for any skin changes.
Now, when do you bring in imaging studies like a mammogram or a testicular ultrasound?
So we don't order these for every patient.
Okay.
If we find a suspicious lump during the exam, then a mammogram is definitely warranted.
Yeah.
And a testicular ultrasound is used in cases of prepubertal bilateral gynecomastia,
Okay.
or if we suspect a testicular mass.
So imaging is reserved for very specific cases.
Right, exactly.
Okay, so what about non-operative management?
So for new onset cases, especially in younger patients, observation is key.
Okay.
Many cases actually resolve on their own within 12 to 18 months as hormones level out.
Yeah.
It's also crucial to identify and treat any underlying causes, whether that's changing a medication or treating a medical condition.
Now, are there any medications that are specifically used to treat gynecomastia?
There are some medications like tamoxifen that have shown some positive results, but they're not a cure-all, and their effectiveness can vary. And actually, testosterone therapy is not recommended for treating gynecomastia
Why is that?
because it's the imbalance between estrogen and testosterone that causes the issue.
Right.
So giving more testosterone might not solve the root problem and could actually make things worse.
What about radiation to prevent gynecomastia? Have you ever seen that used?
Radiation isn't a common treatment for gynecomastia. It's really only considered for men undergoing long-term anti-androgen therapy, such as those being treated for prostate cancer.
Okay.
So a pretty specific situation.
So when does surgery become a consideration then?
Surgery is usually considered for persistent cases, those that have lasted longer than 12 months. And the reason for that is that after about a year, the breast tissue tends to become more fibrotic and less responsive to non-surgical options.
So after that point, surgery becomes a more definitive solution when other approaches haven't worked.
That's right.
Okay. Now, I know there are different classification systems to help guide the surgical approach. Can you elaborate on those?
Yeah, so the two most common systems are the UTSW and McMaster classifications. The UTSW system looks at breast size, the type of tissue, glandular versus fibrous, and the degree of mitosis.
Okay.
It categorizes gynecomastia into 4 grades.
Let's break down the UTSW system a bit. What does each grade entail?
Okay, so grade 1 is minimal hypertrophy, meaning less than 250 grams of breast tissue and no ptosis. Grade 2 is moderate hypertrophy, so that's 250 to 500 grams of breast tissue and still no ptosis.
Okay.
Grade 3 is severe hypertrophy, so it exceeds 500 grams of tissue, and you start to see grade 1 ptosis, so a little bit of sagging.
Okay.
And then grade 4 is also severe hypertrophy, over 500 grams, but with grade 2 or 3 ptosis, so more significant sagging.
All right, that makes sense. Now, tell me about the McMaster classification system. How is that different?
So the McMaster system categorizes gynecomastia into 3 classes.
Okay.
Class 1 refers to breasts weighing less than 250 grams. Class 2 is 250 to 500 grams. Okay.
And class 3 is anything over 500 grams, regardless of tissue type. Both of these systems, they're really used to help guide our surgical decision-making.
So both systems essentially help surgeons figure out the best approach for each patient.
Exactly.
Okay, so what are the main surgical techniques then that are used to address gynecomastia?
Well, liposuction is a mainstay, particularly for cases with mild to moderate glandular hypertrophy and minimal excess skin.
Okay.
For cases with significant glandular hypertrophy or ptosis, we would need to consider direct surgical excision, and then nipple repositioning techniques are used when liptosis is present.
Can you break down the different types of liposuction that are used in gynecomastia surgery?
Sure. There are 3 main types. Suction-assisted lipectomy, or SL. That's the most traditional technique where we use a vacuum to remove the fat. Then you have power-assisted liposuction, or PL, which uses a cannula with a motorized mechanism to remove the fat.
Okay.
And lastly, there's ultrasound-assisted liposuction, or UAL, which uses ultrasonic energy to liquefy the fat before it's suctioned out.
Each technique has its own pros and cons, and the surgeon will choose the best option based on the individual patient.
Choosing the right liposuction technique sounds like a pretty important decision. Can you walk me through the advantages and disadvantages of each approach?
Sure. So SAL is generally well tolerated, and it works well for removing moderate amounts of fat.
Okay.
However, it can be more physically demanding for the surgeon.
Makes sense.
PL, because it's power-assisted, reduces the strain on the surgeon and helps with contouring,
Okay.
but it can cause a little more bruising.
Got it.
And then UAL is particularly beneficial for dense fibrous tissue because the ultrasonic energy helps break down those tough areas. But it does require specialized equipment and expertise.
So each technique has its place.
Right.
When is direct surgical excision necessary?
Direct surgical excision is necessary when liposuction alone isn't enough to achieve the desired contour.
Okay.
So we typically reserve this for cases with a significant amount of excess glandular tissue or more severe ptosis.
Makes sense. What about cases where nipple repositioning is needed? When does that become part of the surgical plan?
Nipple repositioning is often necessary when there's noticeable ectosis, meaning the nipple sits lower than desired.
Right.
And we use various techniques to reposition the nipple-areola complex, including a pedicle transposition, where the nipple is moved while still connected to its blood supply,
Okay.
or a free nipple grafting, where the nipple is completely detached and reattached in a better position.
Those sound like some pretty complex procedures.
They can be, yeah.
So the surgeon has a lot of different tools at their disposal. What are the factors then that really influence the choice of surgical technique?
Well, the decision really is based on the individual patient's anatomy,
Sure.
the severity of the gynecomastia, their skin quality, and, their desired outcome.
Okay.
The goal is to create a personalized surgical plan that addresses their unique needs and goals.
Makes sense. Now let's switch gears and talk about postoperative care. What are the essential aspects of care after gynecomastia surgery?
Well, one of the most important things is the use of a compression garment.
Okay.
This helps control swelling and supports the tissues as they heal. We also advise patients to avoid any strenuous activities or heavy lifting for a period of time.
How long do patients typically need to wear the compression garment?
We generally recommend wearing it continuously for 4 to 6 weeks.
Wow.
Yeah, this helps minimize the risk of complications and provides the best support during that initial healing phase.
Okay. And what can patients realistically expect in terms of outcomes after gynecomastia surgery?
Most patients are very satisfied with the results of their surgery. They can expect a more defined and masculine chest contour.
That's great.
Of course, as with any surgery, there are inherent risks that need to be considered.
Let's talk about those potential complications.
Mhm.
What are some of the risks associated with gynecomastia surgery?
Sure, some potential complications include hematoma, which is a collection of blood under the skin,
Okay.
seroma, which is a collection of fluid, infection, inadequate resection of the excess tissue, poor scarring, contour deformities or asymmetry, and sensory changes in the nipple or surrounding skin.
So how common are these complications? Are there any specific risks associated with certain techniques?
Well, the overall complication rates for gynecomastia surgery vary, with hematoma being the most frequently encountered issue, particularly in open procedures compared to those done with liposuction alone.
Oh,
Inadequate resection is the most common long-term complication and
right.
sometimes requires a revision surgery.
Okay.
For liposuction-only cases, it's important to check for proper skin retraction around 6 months post-op.
So while there are potential risks, they're generally manageable, and the majority of patients have positive outcomes.
Exactly. It's all about balancing potential benefits and risks.
Well, we've covered a lot of ground today. What do you say we continue this discussion in our next deep dive session?
Sounds good to me.
Great, thanks.
Yeah. So let's jump back into the specifics of those surgical techniques.
Okay, so let's say you have a patient with mild gynecomastia, not a lot of excess skin.
Sure.
What are your go-to liposuction techniques for that scenario?
Well, liposuction works well in these cases. We typically use a super wet infiltration technique, injecting a solution to help with the fat removal.
Mm.
And incisions are placed strategically, usually along that lateral infraramary fold.
Okay.
Sometimes we might add more incisions, periorally or in the axilla, just for better access.
Now, what about cannula choice? Any preferences there?
We tend to use a radial cannula pattern,
Oh.
and it's essential to really focus on that dense fibrous tissue in the subareolar area.
Okay.
But we want to avoid the upper lateral pectoral area, to prevent any contour irregularities.
So it's about sculpting. It's not just removing fat.
Exactly.
What are the signs then that you've reached the endpoint for liposuction in these cases?
Well, we know we're done when there's a loss of tissue resistance or when we start seeing a significant amount of blood in the aspirate. That tells us we've adequately addressed the fatty tissue.
What if there's still some subareolar tissue left even after liposuction?
That's common, especially when the gynecomastia is more fibrous.
Okay.
We have a few options there. We can directly excise that tissue. We can use a pull-through technique through a small incision, or even use an arthroscopic shaver.
Oh, wow.
The choice depends on the surgeon's experience and what we're seeing in that specific case.
Interesting. So
Yeah.
when would you choose an open resection over liposuction alone?
So open resection is necessary when we're dealing with more severe gynecomastia, when there's a lot of glandular hypertrophy or ectosis.
Right.
Liposuction wouldn't be enough to get the desired contour in those cases.
Okay, and are there specific incision patterns or approaches that you prefer for these open resections?
Well, we tailor the approach to each patient, but the wise pattern incision is one technique that we use.
Okay.
It follows the natural curve of the areola, allows us to remove that extra tissue while minimizing visible scarring. We might also use a circumareolar incision or a vertical incision, depending on how much excess skin there is and whether we need to reposition the nipple.
Okay, let's talk more about nipple repositioning. What are the different techniques for addressing symptosis?
If there's ptosis, we have to reposition that nipple areola complex to get a natural-looking result.
Right.
The inferior pedicle technique is a common one. We create a skin flap that keeps the nipple connected to its blood supply while we move it higher up.
So you're essentially creating a new anchor point for the nipple.
Exactly.
What other techniques are there for nipple repositioning?
For more severe cases of symptosis, we might use a free nipple graft.
Okay.
And that means detaching the nipple areola complex and grafting it to a new position.
Oh, wow.
It's a more complex procedure, but can be very effective.
So we've covered the main surgical techniques. Let's move on to what happens after the surgery, post-operative care. What are the key things that patients need to know?
Post-operative care is really vital for optimal healing and minimizing complications. And, as we've already discussed, compression garments are crucial. Wearing it diligently helps control swelling, supports the tissues, reduces the risk of fluid buildup.
And how long do they need to wear the compression garment?
About 4 to 6 weeks after surgery.
Okay, and those potential complications we talked about earlier, like hematomas and seromas, how do you manage those?
Well, minor hematomas and seromas usually resolve on their own.
Okay.
We might use needle aspiration to drain larger ones, and sometimes we'll place drains during surgery to prevent fluid from building up.
Okay, are infections a common concern after this surgery?
Infections are rare, but we do everything we can to prevent them.
Of course.
We prescribe antibiotics, and if an infection does occur, we treat it promptly with antibiotics and drainage if necessary.
So early detection and treatment are important.
Absolutely.
What about contour irregularities? How do you minimize the risk of those?
Well, it all comes down to meticulous surgical technique. Making sure things are symmetrical, removing the right amount of tissue, using proper liposuction techniques to get that sculpted look.
Right.
But even with careful technique, minor irregularities can happen.
Yeah.
And in those situations, we might recommend a revision surgery to further refine the contour.
Okay, and then sensory changes are another potential complication. Are those common after gynecomastia surgery?
So sensory changes can happen, particularly with techniques involving the nipple areola complex.
Right.
Patients might experience temporary numbness, hypersensitivity, or a change in sensation.
Right.
But these changes usually improve over time.
So it's important to reassure patients that it's often not permanent.
Right.
Now let's revisit patient satisfaction. We know that gynecomastia surgery generally has high satisfaction rates.
Yeah.
What contributes to those positive outcomes?
Well, several factors play a role.
Oh,
Patient selection is key.
sure.
We need to make sure they're good candidates for surgery and that they have realistic expectations. Clear communication is also crucial. Explaining the procedure, discussing the risks and benefits, making sure they're comfortable asking questions.
Yeah.
And of course, the surgeon's expertise and attention to detail during surgery are essential for a good aesthetic outcome. Well, thank you for joining us for this deep dive into gynecomastia.
Yeah, thanks for having me.
We hope you found this discussion insightful and helpful, and we'll see you next time.
See you later.